Hello, everybody. This is Dr. Kaspar Hermansen speaking from Denmark. Um, I'm going to talk a little bit about immediate versus delayed implant placement in complex situations, and hopefully being able to give you a few surgical and prosthetic tips, at least about how it works in my hands. So this is some pictures from the beautiful country of the Kingdom of Denmark, and as you can see, the country is like this. And right now, I am on a summer holiday in the very northern part of Denmark. So it's a great honor and pleasure for me to be invited to have this recorded webinar with you. I became a Minic Knight in 2018, and my first experiences with AnyRidge goes back to 2014, where my dear friend Dr. Mikkel became a distributor of AnyRidge in Denmark. And he called me and said, listen, Kaspar, I think that you should try this implant because this is something special compared to what you have tried before. And I decided to say, okay, I've always been interested in trying new things, and also in this case, I said, okay, let's do it. And it started out with some pretty normal cases. Here you see a case with a limited height of above the sinuses, so that before we had these more wide and short implants, we had to perform a sinus lift procedure and go with longer implants. But with this implant system, as you know, we have short implants and very wide implants. So if we have a good width of the jaw, we can go for a fast solution and minimizing chair time by not going for a sinus lift procedure. Another not so difficult case, one of my first experiences back from 2014, two premolars that needed to go due to some fracture and implantitis, periodontitis problems. And how does it feel when you work with these implants and just get the feeling in the hands, and how does it work with the prosthetic parts afterwards? So it's we can minimize the chair time and not have to deal with a lot of problems when we go for the prosthetic procedures. Another one of my first cases here is, again, a limited amount of bone height over the right sinus, and with these 7x7 millimeter implants, I could get a really nice primary stability and go for a loading in just about 12 weeks. So and still being able to do screw retained prosthesis, which are my favorite way of doing it. Because it's in my hands, it's not a problem about, it's not a question about if, but it's a question about when some different problems will occur, and when those problems occur, what do we do? And on this slide you see ankylos implant that was placed by another doctor, and the patient couldn't understand that the crown became loose, and this is how the patient presented to me, and it was pretty easy for me to remove it with my fingers. And on the right side of the picture you see the fractured abutment and the fractured tip of the retention screw, telling me that this would be a very complicated case to solve, at least seen from a prosthetical point of view in the first place. Here you see the situation in the mouth, and I will go back to this case a little later and show you how I solved it. First of all, I want to share this little case as well with you. It's a patient coming in referred from another doctor because the crown of this lateral central incisor was loose, and as you can see, the patient has gone through extensive dental treatment before, and a lot of implant has been placed, a lot of post and cores, and now we have that problem with one tooth in the aesthetic zone, and the X-rays shows you here that it would be very difficult if we should replace that one tooth by redoing some of the prosthetical work that has already been done. So this next slide shows us what the problem was with that particular tooth. We have a very complicated root fracture, and in my opinion, there's no other treatment option here than going for immediate implant placement. So in these days, this is a little older case. We did the full extraction of the tooth and didn't go for the partial extraction therapy. But as we know from a lot of previous cases, this technique also works as long as you do it in the right way. So as you can see in the drilling protocol, we still engage the palatal wall and do the osteotomy there, and then the next thing we need is an implant that gives us the possibility to get access to that hole and give us the right primary stability. So the implant goes in. It may seem that it goes into a little wrong direction, but with this implant, as other implants, the AnyRidge implant that has the self-cutting capacity, we can screw it in and we can do the correction of the insertion axis in the end. And then we can mount a provisional temporary abutment and fabricate chairside a acrylic crown that will take care of the soft tissue and give the soft tissue the support that we need in order to have stable conditions, and the patient walks out of the office in maybe 1 hour, 1.5 hours with a nice and satisfying solution. And then after period of healing period, we can change this temporary crown into a final porcelain restoration, and as you can see, we have a nice and stable soft tissue around the restoration, and the patient has had a tooth during the whole treatment period, not having to wear a flipper or a Maryland bridge that we would have difficulties bonding to the adjacent porcelain restorations. Now, talking about immediate implant placement versus delayed implant placement, a case like this would be very time consuming if we should go for a delayed or a conventional approach by extracting the bad dentition that we see in this OPG, and then provide the patients with a couple of dentures and wait for a healing and then go for implant placement. So with the all-on-4 technique, as you have seen or will see in future webinars, we can, with the MegaGen products and the AnyRidge implant, go for a double procedure, upper and lower, in a very efficient and safe way. And by using the multi-unit abutments, we can provide the patients with a couple of provisional dentures or bridges, and the patient will be in function right away and will go from A to C in a very fast and efficient way. I think in my hands, at least, the surgical procedure here would be about a couple of hours, and then we have the registration and the impression taking, and then my technician will go on right away, pour the casts and make the models, and then start to fabricate the bridges, and in 4 or 5 hours later, I would have the bridges delivered, and we can screw them in and check the occlusion and go on from there. For the final restoration of this patient, we went for 2 mil titanium bridges and decided to go for a solution where we did 12 individual cemented crowns onto the titanium framework in the upper, and conventional acrylic restoration in the lower, so that when the patient is biting down, it's not so hard, it's not so noisy in the head, and that's often the way that I do it in my clinic, using porcelain restorations in the upper, where we need maybe a little bit more aesthetic restoration, and then we can go for acrylic in the lower, remembering to tell the patient that the porcelain teeth will wear a little bit more on the lower, and it may be necessary after maybe 5-6 years to change the teeth in the lower, but we can just reuse the same framework, and in a couple of hours our technician can change the teeth, and the patient will have a new bridge in a very easy and efficient way, and we will end up with a happy patient and also a happy dentist. So again, talking about immediate implant placement versus delayed, it's not only bad teeth that we sometimes need to remove, but also bad implants, or as in this case, fractured implants. And this was actually a case. It was a mother to one of my good friends that normally went to another doctor, and the doctor said, okay, I need to remove this implant, and then you need to go to the hospital, and they would do some bone regeneration, and then maybe in 8 or 9 months she would be suitable for, or the site would be suitable for having a new implant. So I took this x-ray on the left, and I saw it was an old Brånemark 3.75 millimeter implant, and I looked at my assistant and said, okay, can you please do a fast surgical setup, and we will do it right away. And she said, of course. And the picture on the right is taken about 20 or 30 minutes later, where we have the trifine in the AnyRidge box that can go down. We know that the inner diameter of this trifine is 4.0 millimeters, and as you can see on the right, it's really easy to go down on the sides of this implant and remove it without removing a lot of bone, and then I know that the outer diameter of the trifine is 4.5, so it was easy to open a 5x5 AnyRidge implant and just put that implant in right away, and still obtain a very nice primary stability due to the nice design of the threads. And I decided to mount a cover screw and waited for some healing. And then on the X-ray on the upper right, you can see I went for a tie base solution that I did with my CEREC. And what I love about this system is that even though the implant is placed a little deep due to the bony defect, I can just choose a different height on my tie base, so I will raise the prosthetic platform and still be able to get away from the implant neck and get some nice soft tissue around there, and we can solve this situation in a very nice and fast way. Now, I promised that I wanted to come back to the case with the fractured abutment and fractured retention screw, and show you how I solved this. Unfortunately, in this case, the trifine in the AnyRidge implant tray was not big enough to go down on the sides of this 5x5 millimeter ankylos, so I needed to remove it the hard way, so to say, with a Lindemann drill. and try to be as gentle as possible, and then remove the top of the implant, and then with the luxator try to get the rest of it out. And I did, and as you can see with this implant, it's really not a good thing when we have complications that you cannot get that cold welded abutment out of the inside of the implant, and that you will have to remove the whole implant. So because as I said, it's not a question about if things goes wrong, it's a question about when they go wrong. And that's also why I love this implant, the AnyRidge implant, so much, is that we can solve problems in a pretty fast and efficient way. But in this case, I ended up with a pretty big hole, but still was able to do immediate implant placement and not go for the delayed solution. So I placed a 6 by 8.5 millimeter AnyRidge and had a really nice torque and a good ISQ value on it. So since it was placed again a little deep, I went for a Healingabutment solution and grafted with some APRF and some xenograft material in the defect, and sutured everything up, and waited for some healing of that side as well. And then after 3 months, we could go in and with the same approach with my CEREC do a final choose a tie base that again was a little higher than normal, so that we could raise the prosthetic platform. And I was again still able to do a screw retained restoration, so that if some problems will occur in the future, it would be easier for me to remove the crown and solve the problems instead of having a cemented solution. So another case with some x-rays where I, due to the 3D bony architecture, again had to place the implant a little deeper. But even though it's placed a little deep, it's still pretty easy from a prosthetic point of view to choose a higher titanium abutment from the MegaGen products, and still being able to do a nice crown with the margins placed at the gingival level. And hopefully these abutments will last in the future. But yeah, time will show us if it's a weak point, that when we have the connection of the crown and so far away from the prosthetic platform. So some of the challenges when we work with immediate placement compared to the delayed approach is that when we extract a tooth like this, we have a big hole, and maybe it's easy enough to place the implant, but what about closing up the socket afterwards? If we have grafted or so on, we need some kind of a material that will help us to keep down the grafting material and to secure the soft tissue anatomy. And that's also one of the things that I really love about this system, is the possibility for all these different healing abutments, and I'm so happy to use them in these cases where we can place the implant and then we can place the healing abutment and just close up the edges with a couple of small sutures, and we will be able to keep down the material, and you know, as you see here, 3 months post-op, we have a really stable situation, and almost nothing happened. So these x-rays shows you know, two different protocols. On the first implant we had the delayed implant placement in the healing side, and then on the number 6 we had a immediate implant placement. So again, I used this big healing abutment to close up the big hole after the extraction, and to help secure the grafting material and secure the socket in a very nice way. So as we know, MegaGen never stops innovating, and that's also why I was so happy when I saw this post in the minute group, that we soon will have the possibility to use these anatomic healing abutments, and we can just choose whatever. If it should be a molar, premolar, or canine that we're working with, we can choose the right healing abutment for the right situation and close up the socket in a very nice way, and have nice soft tissue, so that it will be very efficient and easy for us to go on with the prosthetic part. If you hear some things bashing in the background, it's due to a big storm that has just hit the northern part of Denmark, so I apologize for that, but there's nothing I can do about it. So, um, again, talking about how fond I am about these nice healing abutment. This is another case. Some X-rays first, and then some clinical photos of the situations after the healing, and you can see how nicely the soft tissue is on the right side of the picture, and the small granules you see in attached to the soft tissue is just some of the biomaterials that we use, and if I see those granules and they're in, I mean, I can easily pick it out with a forceps or a plier. I will do that, but if they're integrated in the soft tissue, I will just leave them there and go on and do my prosthetic. But now it's really easy to mount a tie base and a scan post, and then with my CEREC go on and do the prosthetic work, and again going for a screw retained restoration, and so it will be easy for me to take it out if something happens in the future. And here you see the nice design of the MegaGen tie base abutments. We have a huge platform shift, and also these tie bases, as I said before, we can have in so many different heights, and just choose whatever tie base will suit the given situation. Again, if we work with referring doctors, a lot of doctors say, okay, I have this bad tooth, and I can just extract it for you, and then I will send the patient to you. I'm always telling the referring doctor not to. I want to make the extraction myself, because as we know, not every doctor is gentle when they do extractions, and if they destroy the bone, we have some other problems that maybe were not necessary if we had the possibility ourselves to do the extraction. So this case is a typical case that will come in my office, where a referring doctor just took down the bad tooth, but left the roots in place, and now I can go on from there and do my extraction myself and do the planning of the surgery. When I do extractions like this, I always like to take out some blood samples and use the APRF technique and get the nice membranes out of it, so that we will have all of the good stuff from the blood that we can mix up with the biomaterial or the autogenous bone or whatever that we're going to use in the given situation. So again, we decided to go for the immediate implant placement at this molar site, and with the tree fine, I removed this very nice septum that we had between the two roots, and this was what came out of it. And with this Medici device, I could make small particles out of this piece of autogenous bone, and in this case I decided to do what I call the superpower mix, which is a mixture of autogenous bone, APRF, the plasma, and then the xenograft material, and we can mix that up and then use that as a grafting material. So now the only osteotomy that I have actually done is still with the tree fine, and I know that the inner diameter of the tree fine is 5.0 and the outer diameter is 5.5. So in this case I chose the 6.0 millimeter implant and just placed that right in the septum where I did the osteotomy with the tree fine. So on the X-ray, you see the pre-op situation, and then the post-op. And in this case, I actually placed a cover screw and decided to cover it up with some APRF membranes and suture it up. But still had some really nice healing. As you can see, already after 1 week, it looked really nice. So after 2 weeks, I decided to change the cover screw to a healing abutment, and then again after a period of healing, you can see the very nice emergence profile due to the S shape of the healing abutment, and now it's easy and very efficient to go on for the prosthetic procedure. So here you have the prosthetic delivery, again crown made in lithium disilicate with the ceric, a prefabricated titanium abutment in this case, and a cemented crown, but still very nice soft tissue around everything, and a nice and a good platform shift. I still don't understand why other implant brands stick to those hopeless healing abutment as you see on this screen. I mean, it's talking about minimizing chair time. It's definitely not easy to go from a healing abutment and a soft tissue that comes with the uses of this to fabricate a nice crown with a nice emergence profile. Now, talking about immediate implant placement versus delayed implant placement, this is another example of a case where, in my opinion, immediate implant placement is the only right solution. This is a patient who has undergone a big trauma due to a bicycle accident, and his upper incisors are both pretty protruded, and as you can see on the x-ray, we have a deep placed horizontal root fracture. So I decided to go for the procedure, and took out the root and the tooth very carefully, and I decided to take the patient's own tooth and have my technician to hollow the existing natural tooth while I was performing the surgery. And this is how it ended up. And then after placing the implant, I could take an impression, and my technician could use a fast setting gypsum, and a prefabricated titanium abutment, and then just reline and polish the natural crown with some flowable composite and some acrylic. And in a very short period of time, I was able to mount the natural tooth to the placed implant, and we definitely have a procedure that maybe only took about 1 hour totally, and the patient walks out with a result that was good compared to how it looked when the patient came in. So after 3 months, I saw the patient again and removed the provisional crown, and could see that we really ended up with nice soft tissue conditions and a nice emergence profile, and almost no retraction when we compared the situation after healing with the initial situation. So far a satisfying result. So I decided to go for the final crown, and in this case I had to use a titanium abutment and do a cemented zirconia crown on top of that. In this case, it would have been really lovely if MegaGen would provide us with the angulated screw channel abutment, because that would have given me the possibility to still make a screw retained crown, and not having to deal with the problems with cementation as we know. So the final case that I would like to share with you in this webinar is another trauma case, and this time it's a beautiful young lady who fell and hit her mouth to the asphalt, and that was the result. A very complicated fracture on her incisor, and as you can see in this case, the fracture line was more incisal placed than in the previous case where we had the very deep horizontal root fracture. So in this case, I decided to go for the root membrane or the socket shield technique. And as you can see on the upper left, MegaGen developed a special root membrane kit with all the nice drills and special drills and long drills that we need in order to perform this procedure in a safe and precise and right way. So I didn't have time to do the procedure right away, so because that of course needs some planning. So I just did some pain control and removed the loose fragments of the enamel and took away the pulp, and then inspected the rest of the tooth to see whether the buccal part of the root was mobile, because as we know from the literature, if the buccal root the part or buccal part of the root is mobile, we have to remove everything because otherwise we will end up having troubles. In this case, luckily, the buccal part was not mobile, so I decided to go on with the root membrane technique. We did a CBCT, and as you can see, we have this very thin buccal plate, and the whole idea with the root membrane technique is to preserve that buccal bone and thereby preventing that we will have soft tissue retractions and aesthetic problems due to loss of bone. And the procedure is not, at least I think, in my hands, not a really easy procedure. It takes some time to go down and go in the right direction and to divide the root in the right way. And yeah, it takes some time and needs some training, of course, with everything else. So this picture is a picture that I got from Dr. Howie Gluckman from South Africa, and it's a really nice picture because it shows some of the problems that, or not problems, but some of the issues we have when we go with high-speed drilling very deep down in the root, because it's very hard to get sufficient cooling, and the patient will sometimes react on the bad smell of burnt tooth, even though we have strong suction. So after preparing the shield, we can do our osteotomy, engaging the palatal wall as we have talked about before, and the implant can be placed. And then I can take an impression and have my technician to do a temporary acrylic crown that can be screw retained. And as you can see, the temporary crown is a little shorter and a little smaller than the natural tooth, but that's on purpose because I don't want to put excessive forces when it comes to occlusion and lateral protrusion on this temporary crown. After 3 weeks, I had the patient coming back and to see if everything was looking nice, and you can see that we've been able to keep this very thin biotype gingival contour on the site where we have the socket shield and the implant, and I removed this provisional crown just to see if everything looked nicely, and as you can see, there's a little bit of exposure on the shield at the very buccal aspect, and that sometimes happen because it's very difficult to make sure that the provisional crown has the right contour so that it will support the soft tissue, but it will not touch and push on the shield. So what I just did is that I reduced the acrylic on the temporary crown just a little bit and polished it up again, and then I mounted the crown again and had the patient to come back after 3 weeks again, and then you could see that um, the shield is not exposed anymore, and we have coverage with soft tissue and a very nice soft tissue contour that we can now scan or take an impression of, and then have our technician to fabricate the final screw retained crown. So this is how this case ended up with the final crown. Very nice soft tissue contours, no retraction at all. A little bit of bleaching on the soft tissue due to the crown just being mounted, but I always wait 5 or 10 minutes to see whether that little bleaching is or blending is going away, and if not, I will have to take out the crown and reduce the buckle aspect a little bit more, but in this case it went nicely, and the x-ray shows us very stable bony contours at the level of the implant neck, and we can see that the shield is integrated and everything looks stable and nice. And first of all, the young lady is now able to smile again and socialize, and not only smiling with her beautiful smile, showing her teeth, but also smiling with her eyes. So with this last picture from the west coast of Denmark, I would like to thank everybody that had the chance to watch this little webinar. I hope that you had some useful information that you can take into your clinics, and I would like to thank Sean and Susan for giving me the opportunity to participate in this series of webinars. If there are some questions to some of the material that I have presented, everybody can feel free to contact me on my email, and I would do all the best that I can to answer it. So with these comments, I would wish you all a very nice summer and summer holiday when you get there, and hopefully we can meet and see each other soon in the future. All the best. Bye bye.